And once you start doing things to the patient but not for the patient, physicians need to begin to ask themselves the questions and to be a little more paternalistic, quite frankly, beneficent paternalism, and help to guide families, not be afraid of making recommendations. There's this reliance on autonomy, and we sometimes think it's a Chinese restaurant and you can order the mugu gai pan or the sushi, but it's actually a shared decision-making that needs to play out to help this go better, I think.
I want to pick up something that Stuart said, and I don't think really meant the idea of care versus cure with the verses. I think part of the resistance to hospice is that sense that those two are separate entities. We should be caring for people from the time they're born until the time they breathe their last, and even perhaps doing well by their funerals. But there comes a point where the interventive technology, even though we have that yearn for immortality in our current bodies, is no longer doing us any good, but in fact is a burden, the intensive care you mentioned. So it isn't a versus, it's a continuum where the care is always there and the fight for the cure may at some point have to drop off.
Question for Dr. Kodish. You, on a couple of occasions, drew a distinction between active euthanasia and physician-assisted suicide. Are we talking about who's pushing the button here, or is it something more defined than that?
Yeah, I think it's a little bit more defined than that because the physician-assisted suicide is, at least it works in Washington and Oregon, and I'm not familiar with, you said Montana, is the writing of a prescription. So physicians serve as what's called a learned intermediary according to the FDA. They have prescribing authority, and they can write a prescription with the indication being suicide in these particular states. I think that that's a very different thing than doctors physically pushing the button or killing, and it's probably the topic for another City Club forum, but the role of physicians in execution has been much in the news and I think connects very much to these issues. So there was an old New England Journal paper in the late 80s simply titled "Doctors Must Not Kill." And I think that says quite a bit. Physician-assisted suicide, at least in my view, isn't an example of doctors killing, but it's giving control to patients to commit suicide. Anybody want to add to that?
I would. I mean, there are people who disagree with you. I'm not sure I'm one of them, but it certainly feels different that to give the patient the means. You know, so what if you just give the patient a button to push, and instead of you pushing the button, the patient pushes the button? What's, you know, is there a difference? Well, there is sort of a difference, but it's giving the patient the prescription, the patient goes to the drugstore, takes the stuff home, it sits there, then the patient takes it. Is that any different than fixing up the thing so the button's there and then the patient? Well, it is a little bit different, but they're both physician-assisted suicide. So it gets a little tricky. It's interesting. One of the problems with committing suicide for patients is that it's actually hard to kill people and hard to kill yourself. I mean, you can, you know, put a shotgun in your mouth and then it's pretty sure. But taking pills is tricky, and there are lots of stories of people who try to do it and end up in worse states. You know, they vomit, they aspirate, and then they're in worse states. And in the Netherlands, where physician-assisted suicide is an option, they do insist that the doctor be there until the patient dies. And there have been instances where the patient didn't die and then the doctor ended up killing the patient. And so the doctors and the patients, if they have to do one of them, they tend to drift towards the other. It's just an interesting, but they're not allowed to give them a prescription to go home and kill themselves.
I think I have a problem with the technology and in the committing suicide. It seems to me that the emphasis should be on the patient's right to allow their life to end as opposed to committing suicide. But if they need some assistance in being able to reach that end, they should be able to get it. And certainly the directives would point in that direction. So maybe you could talk about the terminology.
Well, when you're saying they should be able to make a decision but not suicide, so what if the decision was, doctor, write me a prescription for pills? Would that be suicide?
Well, I guess what I'm looking at is the patient being allowed to decide, I'm ready to die and I don't want to have my life prolonged.
Right.
And giving me something, having that prescription, whether I choose to use it or not, is my choice as opposed to...
Right, but if you take it, aren't you committing suicide?
Is it committing suicide or just allowing myself to die?
Well, if you take a pill to kill yourself, it's going beyond allowing yourself to die. See, a lot of this is language, and we often think we're solving a problem by giving it a name. So, well, and I know the group that spoke here before wants to get away from that term. Well, they want to get away, a rose by any other name would smell as sweet. There's certain things. So what you describe, it's killing yourself.
I think another helpful way to think about it is removal of barriers to someone's death. Again, the active-passive distinction is very helpful to me, and in my faith tradition, it's a concept of removing barriers. If someone is dying, the technology, whether it's artificial fluid and nutrition, dialysis, antibiotics, these are barriers to a person's passing away. And I think it's ethically acceptable to remove barriers, but perhaps not to hasten the death, with the exception of the double effect that you mentioned.
Yeah, the other thing with regard to a physician intervening to help in a very active way, giving you the pills, writing the prescription, giving you the machine that you can take, that you also you've got two moral decisions there. One, the part of the patient who wants the autonomy, which, by the way, is a prerequisite, not a guarantee that what I choose autonomously is the right thing. But you also have the physician's autonomy to make choices which he or she believes to be right or wrong. And if I'm the physician, no matter how much you wish to die, you have no moral claim on me to help you to do it. Does that make sense? I mean, I can sympathize with you, I can understand your choice, but it would be as if you came to me and said, I don't like my left arm, please cut it off. That's sort of clear because we wouldn't want to do that. But you have a right, in a sense, to make that choice, but you don't have a right to pull me into the choice with you if I'm the physician.
Today at the City Club of Cleveland, we've been listening to a special program featuring Dr. Dolores Christie, Executive Director of the Catholic Theological Society of America, David Simpson, CEO of Hospice of the Western Reserve, and Dr. Stuart Youngner, MD and Chair, Department of Bioethics, School of Medicine at Case Western Reserve, and our moderator is Eric Kodish, MD and Chair of the Department of Bioethics, Lerner College of Medicine at the Cleveland Clinic. Thank you, panelists and moderator, and thank you, all of you, for coming and joining us today. The City Club is now adjourned.